My name is Evangelos Giamarellos. I'm professor of internal medicine and infectious diseases at the University of Athens, and I would like to thank you for this very nice invitation and kind words to present the complex thing in dysregulation that is taking place in COVID-19. This is my conflict of interest disclosure for this presentation, and I would like to start with what is the general concept for severe COVID-19. Severe COVID-19, I mean, generally, is considered a patient who's infected by SARS-CoV-2, who has severe respiratory failure, who's under mechanical ventilation, and the idea that was actually the first readout for these patients is that this is a situation of acute pro-inflammation. As a matter of fact, you see in both panels, in the left panel, you see the concentration of IL-6. In the right panel, the concentration of CRP. And you see that as the patient is getting worse, the admission values of IL-6 and of CRP are increased from non-ICU survivors to ICU survivors and non-survivors. And actually, it was recently published, although in cohorts of a small number of patients, 20 healthy, 20 stable under COVID, 20 severe under mechanical ventilation in the ICU, and compared with patients with community-acquired pneumonia, that there is a pro-inflammatory anti-inflammatory imbalance. Look here, the concentrations of IL-1 beta, IL-6 are higher as we move to more severe COVID, but surprisingly, IL-1 beta and IL-6 are higher in severe COVID than severe CAP. And IL-10, which is an anti-inflammatory cytokine, is higher in severe CAP than severe COVID. And the ratio of IL-6, IL-10, which represents the pro-inflammatory and inflammatory imbalance, is higher in severe COVID-19 than severe CAP. However, all of a sudden, we learned that although IL-6 is higher in survivors than in non-survivors, a protein, which is known as ferritin, is also higher in non-survivors than survivors. And having so much high values of ferritin is something against which we're not accustomed. And then the question is, how ferritin is there? We know that ferritin is increased in situations where there is activation of macrophages. We learned the last 3 years that macrophage activation syndrome is an independent situation in sepsis, in bacterial sepsis, which is associated with early mortality after 10 days. This logistic regression analysis is some data coming from patients of the Greek Registry of Sepsis, split in 2 cohorts, cohort A and cohort B, and a situation that we called macrophage activation-like syndrome was an independent driver to early death, even when ARDS, acute kidney injury, and shock were there. And then we learned that ferritin at very high concentrations, more than 4.4 thousand nanogram per ml, it measured the first 24 hours from the start of sepsis, was an indication of death. Look here in the first cohort, in the second cohort, in cohort B, exactly the same thing, and an independent cohort coming from Sweden, from a completely different environment of healthcare. Concentrations of ferritin that make more than 4.4 thousand nanograms per ml are associated with early and late mortality. In such a case, where these concentrations, they have a specificity and a negative predictive value close to 100% for the diagnosis of what we call macrophage activation-like syndrome. How can the syndrome be diagnosed? So the one option is ferritin. And the other option is to measure a clinical score which is known as the HS score, and for which a patient gets points for 9 variables: temperature, hepatosplenomegaly, decreased blood cell counts, increased triglycerides, decreased fibrinogen, increased ferritin, increased transaminases, presence of bone marrow hemophagocytosis, and immunosuppression. So that's one way. But although we know that in sepsis there could be macrophage activation syndrome, we also know in sepsis that there is sepsis-induced immunosuppression. And the question is whether this sepsis-induced immunosuppression could have similarities with COVID-19 leukopenia. What could be these similarities? We know already that mortality in sepsis is associated with a decreased expression of HLA-DR monocytes, and in parallel, we know that patients who are dying from sepsis, they are dying under a state of sepsis-induced immunosuppression that has the characteristic of the inability of our monocytes and our macrophages for the production of cytokines. So based on this, we use those tools on one part ferritin, and on the other part, the expression of HLA-DR and monocytes. And we ended up, and we compare patients with COVID-19 with patients with severe pneumonia. And we ended up that cases of severe pneumonia who are not in need of a ventilator, many of them are under an intermediate state between immunosuppression and macrophage activation syndrome. However, patients with COVID-19, all of them with severe COVID-19, they have either immune dysregulation, either macrophage activation syndrome. Look at the ferritins. We split our patients into those who are in an intermediate immune state, in those who are under a situation of immunoparalysis for sepsis or dysregulation from COVID-19, and patients with macrophage activation syndrome. You see that in these three strata of classification, ferritins do not differ, but please pay attention to the fact that among patients who are severe, and the severe patients are either in blue or red, severe COVID, 1/4 of them, they have a HS4, which is high and which is indicative of macrophage activation. Look at the HLA-DR. The HLA-DR is high in intermediate immune states. It is low in patients with immunoparalysis by bacterial cap and dysregulation by SARS-CoV, and it is low in patients with macrophage activation syndrome. And we would anticipate that if patients with COVID-19, they behave, the function of their monocytes, the monocytes who have a decrease of HLA-DR is similar to bacterial sepsis, then we would anticipate that their circulating mononuclear cells would not be able for the production of IL-6. But on the contrary, we see that the monocytes coming from patients with severe COVID, they're able for the production of IL-6. And even if you compare them with severe influenza, they're even more prominent for the production of IL-6. In other terms, we have in front of us, in the situation of severe COVID-19, something which is bizarre, which is unique, which has never been presented so far, where monocytes lose HLA-DR but maintain the ability of cytokine production. And the higher the IL-6 in the serum, the lower the HLA-DR expression on CD monocytes, which generates the question if IL-6 is the driver for it. In order to discern that, we isolated PBMCs from patients who were under this state of immune dysregulation. When we incubate these patients with medium, then the HLA-DR expression is quite well. Once we add the plasma of these patients, HLA-DR goes down. And when we add tocilizumab, tocilizumab is a blocker of IL-6 receptor, the HLA-DR expression capacity goes up. And as a matter of fact, you see here a situation of 6 patients under the state of immune dysregulation. They start with a low HLA-DR expression on their monocytes and a low absolute lymphocyte count. 24 hours after treatment with tocilizumab, absolute lymphocyte count goes up, and 48 hours, it is even higher. So this leads us to the conclusion that there are 2 mechanisms in severe SARS-CoV-2 that drive the impairment of the patient. So this is the virus. The virus is visiting a host and induces pneumonia. In this induction of pneumonia, the patient has bilateral infiltrates. He has a moderate increase of CRP, of D dimers, and of transaminases. This patient is able for a vivid antigen presentation on monocytes. All of a sudden, this patient deteriorates. He develops severe respiratory failure and he's in need of a ventilation. And this need for ventilation could be driven by two mechanisms. The first mechanism is taking place in 1/4 of the patients. It's driven by IL-1 beta. Why driven by IL-1 beta? Because these patients, they are some of the characteristics that I showed you earlier of macrophage activation with high HS score, with high ferritins, and macrophage activation is always driven by IL-1 beta. In these patients, CRP, ferritin, triglycerides are sky high, the dimers are increased, transaminases are increased, monocytes, they maintain an ability for hyperproduction of TNF, IL-1 beta, and IL-6, and antigen presentation is moderate. However, 3/4 of these patients, they're under this bizarre immune dysregulation, which is driven through IL-6. CRP is increased, D dimers are increased, transaminases are increased, and there is weak antigen presentation with a decrease of HLA-DR expression on monocytes. This gives the pathway for the induction of lymphocytopenia, which is unique in these patients. The decrease of CD4, CD8, and T17 lymphocytes, decrease of lymphocytes, of immunoglobulins, of NKT cells, and NK cells. Thank you very much.